If I can welcome everyone, and thank you so much for joining this session on Beyond COVID, Planning for Future Care and Health Workforce Needs. Also want to let you know that we'll be recording this session for those who can't make it today, and also for those of you who want to share the presentations and the discussion with others after the event. This session is very timely given the increasing importance of resilient care ecosystems and health workforce planning in the wake of COVID. Due to the uptick in unpaid care work and a rising demand for specialised childcare, disability care and elder care services in large parts of the region. The Asia Foundation is increasing its focus and work in these areas across Asia and the Pacific. It's important to understand the need for an intersectional approach to strengthening care policies and broader health workforce planning to ensure access to decent care work, choice of care, and dignity of care. Many of those most impacted during COVID, as we know, were healthcare workers having to work long hours in unsafe environments for low remuneration. The intersecting impacts of COVID, climate change, and conflict mean that there is an urgent need for effective approaches to care delivery systems and health workforce planning in the time ahead. Hearing about the momentum, the issues, the learning, and the opportunities in this space is really important for staff across the Foundation, together with our partners, our donors, and our allies. And so hence this event today. And so now it's my great pleasure to introduce our illustrious speakers for this session. And my colleague Anuja is also posting their bios in the chat. And I'll introduce our speakers in the order in which they'll be speaking. Ankita Panda is my wonderful colleague, a Senior Program Officer for Women's Empowerment and Gender Equality, and she co-leads our work on the care economy. Ankita is just back from Kigali in Rwanda, where she spoke on the opening plenary at the Women Deliver pre-conference on the care economy, which we co-organised with our partners. Next month, Ankita will speak at APEC on a panel on the care economy organised by the US Department of Labour. And today, Ankita is going to be sharing the momentum for a global roadmap on the care economy, focusing on strengthening care policies, delivery systems, and intersectional movements for care justice. I'm also delighted to be introducing Mark Cormack and Ian Crettenden, as I worked with them both over a decade ago now, when Mark was leading Health Workforce Australia and Ian was leading the data collection and analytics, and he later succeeded Mark. And I was leading the stakeholder engagement. Health Workforce Australia represented a visionary and game-changing commitment to planning for the country's future health workforce needs. And it's really a model for other countries and communities. Since then, Mark and Ian have been involved in creating the National Centre for Health Workforce Studies at the Australian National University in Canberra, building on the work, learnings and opportunities catalysed through Health Workforce Australia. And I'm also delighted to be introducing Fan Shun, who is now also joining us as the inaugural director of the National Centre for Health Workforce Studies at the Australian National University. During her tenure at the Australian Commonwealth Department of Health and Aged Care, Fan spearheaded the Department of Australia's first national aged care workforce planning model. So with this introduction, Ankita will speak for 10 minutes, followed by Mark, Fan and Ian, who will jointly present for 50 minutes, and we'll then have 30 minutes for questions. So please start thinking about those questions that you'd like to ask. You can start posting those questions in the chat now, or you can raise your hand once we open for questions. So with that introduction, Ankita, the floor is yours.
Great, thank you so much, Jane. And hi, everyone. I'm really excited to see all of you and to share a little bit more about a recent convening that Jane mentioned that the Asia Foundation had held earlier this month at the Global Women Deliver Conference in Kigali, Rwanda. Just in case you're not familiar, the Women Deliver Conference is the largest conference focused on gender. It takes place every other year. And this year, the conference brought together over 6,000, I believe 6,500 people in person to Kigali, Rwanda, and then another 200,000 participants joined remotely. The Asia Foundation was invited to co-organize a pre-conference on the care economy, which took place on July 16th, the day before the official Women Deliver conference kicked off, and which convened about almost 100 participants from across the world representing governments, the civil society, and the private sector. The theme for the pre-conference was strengthening care policies and intersectional movements for care justice. And the pre-conference was designed specifically to build on existing care-focused convenings by translating existing insights related to the care economy into concrete recommendations and actions for building resilient care ecosystems. Now, if you can go to the next slide, I can share a little bit more about why we decided to organize the convening in the first place. Jane already alluded to this earlier, but the COVID-19 pandemic, as well as climate change and other global crises, have really upended the global economy, and they've laid bare some of the fragilities and the inadequacies of global care systems, so global childcare, elder care, and disability care systems. Across the world, we saw an uptick in both paid and unpaid care, and we saw declines in women's labor force participation, as well as women's outcomes in healthcare and education, amongst other areas. Women were especially hard hit by the pandemic, as they were amongst the first ones to be pulled out of the workforce or out of schools in order to provide childcare, elder care, and disability care. We found that this was particularly true in Asia and the Pacific, as pervasive patriarchal norms really placed the burden for providing this kind of care almost entirely on women and girls, many of whom come from the most structurally disadvantaged backgrounds. When we talked to our peer organizations and donors and other experts on the care economy, we found that very little data and evidence currently exists when it comes to building resilient care ecosystems, which is why in November 2022, just on the sidelines of the G20, the Asia Foundation decided to organize a regional convening to focus on building resilient care ecosystems. And this convening, called the Bali Care Economy Dialogue, brought together over 80 representatives from governments, the private sector, civil society, multilateral institutions, and others to really elevate the care agenda. In other words, why do we need to talk about the care economy, and why does it matter? To help ground the discussions in Bali in the latest evidence, we also developed a white paper, a draft of which was presented in Bali to share the latest data and evidence as it relates to the care economy. And we also subsequently both published the white paper and a regional roadmap for action, which provides specific actions for how we can collectively come together in order to advance the care economy in Asia and the Pacific. And this really led to the pre-conference at Women Deliver, which I'll go into in the next slide. Great, thank you. In February of this year, Women Deliver approached the Asia Foundation and other organizations to co-organize a pre-conference that would really build on the Bali Care Economy Dialogue, but would be more global facing. And the pre-conference was specifically designed in a way to take some of the insights that came up in Bali and in some of the other regional convenings across the world, and to take some of these insights and translate them into concrete policies, recommendations, and actions for care delivery, which again goes back to our theme for the event, which is strengthening care policies and intersectional movements for care justice. With our other project managers, we organized a pre-conference with 5 specific objectives in mind, which you can see here on this slide. First, we wanted to identify gaps and opportunities for concrete, tangible policy action. Second, we really wanted to elevate the care agenda across different global platforms, including the G20, G7, APEC, and other global platforms like those. Third, we also wanted to provide a platform to discuss the adaptation and scaling of best practices from one region to another. We knew that there have been multiple best practices and multiple care strategies that have been working in Latin America, amongst other regions, and we really wanted this convening to be an opportunity to discuss how can we take some of those practices and employ them in other regions of the world. We also wanted the pre-conference to propel and leverage funding investments in care from diversified funding sources. And finally, it was really important for us that the pre-conference would be an opportunity to promote greater joint learning, knowledge sharing, and movement building across the care ecosystem. And ultimately, the goal from all of these different objectives was to feed into the output of the pre-conference, which was a global roadmap for action, which we're hoping will present our collective recommendations and asks for advancing the care economy. If you could go to the next slide, please. And while I've been talking about all of this from the perspective of the Asia Foundation, I just wanted to highlight that this has very much been a team effort. We organized the pre-conference on the care economy with some wonderful partners. Other project managers included the Center for Global Development, the We Prosper Coalition, the International Labor Organization, and Women Deliver. But in addition to the project managers, we also worked with a host of incredible partners who contributed in some way, whether it was technically, administratively, or financially. And you can see some of these organizations here at the bottom half of the slide. And if we can go to the next slide. I just wanted to take a little bit of time to share a little more about the agenda that we co-organized with all of the different partners. The agenda covered a range of different topics and sessions, and I wish that we had more time to go through each of these different sessions in detail, but I'll try to be brief. The event included a combination of both panel discussions as well as more interactive roundtable discussions. We had 4 panels, which included an opening plenary. Jane mentioned this earlier as well, but the opening plenary invited 5 speakers who led regional convenings on care to share some of the key outcomes from their convenings and ways in which those convenings contributed to the pre-conference. I was fortunate in being able to represent the Bali Care Economy Dialogue in this opening plenary, but we also invited speakers from the Latin America region, from Sub-Saharan Africa, and another speaker from Asia and the Pacific to also share some of the outcomes from similar convenings that they held on the care economy. We also had a discussion on care and movement building in Sub-Saharan Africa, and this was especially important as Women Deliver was being held in Rwanda this year. We had another panel which focused on elevating the care agenda in global and regional platforms such as the G20, G7, and APEC. And this really focused on how can we take some of the conversations that are happening on the care economy to these pivotal global movements and moments with policymakers so that we can gain traction and investments in the care economy going forward. And finally, our last panel focused on care financing mechanisms, with the biggest takeaway that emerged from this panel really being the need to engage with diverse actors in order to secure adequate care funding. And then finally, as I mentioned, we had a number of different roundtable discussions, and they covered a range of topics. Unfortunately, we won't have time to go into it, but one of the roundtables did specifically focus on the intersection of care and healthcare, which is really relevant and for which we're all meeting here today to discuss that intersection in particular. And if you could go to the next slide. Through the day-long discussions, we were able to come up with a lot of different recommendations that will ultimately feed into the global roadmap for action. But I thought it might be helpful just to share some of the more common recommendations. They include to define and demystify the care economy by conducting awareness campaigns and storytelling initiatives that feature the voices of unpaid care providers. To invest in qualitative, quantitative, and participatory data to address gaps in evidence on the care economy, to create more diverse financing mechanisms for the care economy, to prioritize interventions and research that really explore the intersection of care and other sectors, such as care and healthcare, for which there isn't a lot of evidence to date, to feature the voices of care workers front and center, particularly in key policy-making forums. And finally, to identify, adapt, and socialize practical, innovative, and proven models to facilitate care delivery. And if you could go to my last slide, that's a little bit of where we are right now. In terms of the next steps, we're working on a few different things from our end. The program managers are currently in the process of synthesizing the recommendations that emerged from the pre-conference into a draft global roadmap for action. We will share this draft and conduct consultations with our partners and others who want to contribute to the global roadmap for action. Our goal is to finalize it by the International Day of Care, which will be on October 29th. And finally, we hope to socialize this roadmap at some of the key global moments that I mentioned, such as the G20, G7, and others. And that's where we are right now. Happy to answer any questions, but I believe my time is up, so I'll pass it back to Jane.
Thanks so much, Ankita, for that fantastic presentation. And now invite Mark and Ian and Fan to give their presentation.
Thank you very much to meet with you today and to discuss a critically important international topic. If I could just go to the next slide, please. What we'd like to cover today is really three main areas: how we analyse this health and care workforce problem that we're all trying to address, a little bit about what the centre is focused on, and then Ian will give some detailed description of our approach to health and care workforce planning. Next slide, please. Before I go any further, I'd just like to acknowledge the traditional owners and custodians of country throughout Australia and acknowledge their continuing connection to land, waters and community. And I pay my respects to the people, cultures and elders past and present. Next slide, thanks. And the one after that, please. So this is really our kind of system view of the health and care workforce. And I'll just zone in initially on that band across the middle, which has got the supply and demand boxes. Essentially, what we're all trying to address is a classic economic problem of supply and demand mismatch, which is global in nature, but varies a bit from region and country to country. Essentially, on the supply side, it's really about the quantity, the distribution, the movement of the labour force throughout an economy. On the demand side, it's really driven by population, disease burden, economic factors such as gross domestic product, technology changes, utilisation, and most importantly, policy changes. This framework presents really the 6 core policy tools that are available to governments and available to industry. In the supply side, there's the policy lever of training, making sure that there are enough fit-for-purpose workers in the economy at any one time. The second one, slightly more contentious, is the use of skilled international labour flows through the migration policy settings. The third area really focuses on policies that are aimed at attracting people to enter the workforce, discouraging them from exiting, and also encouraging them to increase or decrease their work hours as required. On the demand side, there are 2 main policy levers. The first one is the design of the healthcare and the health and care system as a whole, the roles and responsibilities that health workers perform within those systems, and the scope of practice or the range of tasks that individual workers are permitted to do. And the final demand policy lever is really around payment and reimbursement mechanisms. How and how much workers are paid has an enormous impact on the availability of supply to match need. And running along the bottom are the regulation levers within the economy. Who can enter a profession, who can practice a certain way, what rules apply to certain procedures such as the ordering of tests, the distribution of drugs, or the performance of certain health and care related functions. And the diagram also points to the criticality down the bottom of accessing data, information, surveillance, intelligence and research insights to enable that as a resource for the governance layer, which is the top of the diagram, the decision-making layer about the healthcare system, and also the next layer down, which is really the leaders and managers who run health and care organisations. Next slide, please. Just quickly running through problems and challenges that I think we're all aware of. Certainly, there are numerous disparate healthcare providers and very diffuse governance arrangements in virtually every economy around the world. It's not all neatly organised to solve the problem. The second point, powerful actors and interest groups exert significant control over government policy, who does what, how they get paid, who can enter and exit and participate in the health and care workforce. Complex funding arrangements have a significant bearing on the way the health and care workforce is able to meet supply and demand requirements. There are boundary issues where, and this is very relevant to the topic today, where we have a workforce that in many instances works across the health, aged care, disability, childcare and other sectors, but it's essentially a mobile and very similar workforce. And critically, how we're able to coordinate workforce planning. Next slide, please. Other problems and challenges are really measuring and controlling workforce supply, focusing on what we'd call choke points in the supply chain. There can be barriers and restrictions to domestic training. That can be economic. It can be the lack of availability of practical places to learn the art and craft of being a health worker or a health and care professional. There can be very long training pathways, especially for doctors and certainly in Australia, other professions such as psychologists, and there can be regulatory barriers. Workforce distribution is a primary concern globally, with people typically in the outer metropolitan, rural and remote areas often missing out on the best quality workers. How we account for technical and practice innovations that are either driven by professional groups or are driven by research breakthroughs. These have an enormous impact on equipping and making the workforce available. And the final key challenge here is professional boundaries, who does what, professional roles and scope of practice. And in many countries, these are very tightly regulated, and that regulation, while may serving the purpose of protecting the health and well-being of the population, can also impose artificial restrictions on who does what, where they can perform their vital health workers, and indeed how much they get paid. Next slide, thank you. I guess just a quick reference to the Health Workforce Australia experiment, which ran in Australia from 2010 and 2014. And Jane referred to that in the introduction. It was essentially a federated solution to a federated problem. Australia, like many countries around the world, is a federation, has a national government, has a series of subnational or regional governments. The institution was governed collectively by the 9 main jurisdictions, the national and the subnational governments. It was given a range of functions about national workforce planning, data and modelling, the management of supply through health professional clinical training, capacity and innovations and migration policy. It also oversaw a range of reforms to develop and account for improved workforce models, and also assisted greatly with collective organised engagement with powerful stakeholders and actors. Regrettably, it was abolished in 2014 as part of a national austerity drive following a change of government in 2014. The Conservative or coalition government was focused on small government and really big cuts to federal expenditure. So while it performed a vital function in that period of time, I guess the main limitations through any of these mechanisms, and there are many countries that have tried these different national coordinated approaches, there's always the challenge in a federation of intergovernmental management. how governments work with each other and work with the national government, the regional government and the local government, all of whom have specific responsibilities to perform. And my final comment, which is then a segue to Fan to describe the work of the centre, is that we've now, I guess, in many ways chosen to focus on an academic-led pathway that focuses on building research, evidence, education, and government and industry partnerships to address the problem that Health Workforce Australia was established to address back in 2010. And in fact, the problem of scarcity in health workforce is no better now than it was, back in 13 years ago. But I'll just stop at this point and just transition to our next speaker, who is Fan Jung, who is the director of the Centre for the National Centre for Health Workforce Studies. Thank you.
Next slide, please. Thanks very much, Mark. Hi, everyone. My name is Fan Zhang. I am a director of the National Centre for Health Workforce Studies, and I work closely with Mark and Ian, also a group of passionate researchers, data, and policy analysts on this exciting journey of building Australia's national leadership program to really improve the health workforce outcomes. So for the next part, I'm going to talk about our centre's work, including a few current projects. As Mark just alluded, so it is about time that these long-standing health workforce challenges are rethought, recalibrated, also better informed by data and evidence, and supported through effective partnerships with governments, industry, and higher education professionals. So here in Canberra, the Australian National University provides strong research and education support, also an independent platform where the National Centre for Health Workforce Studies was established within its College of Health and Medicine. Next slide, please. At the moment, the scope of our centre's work includes 4 key components. First of all, we are building a new national academic capability in health workforce data, surveillance, modelling, as well as intelligence. Secondly, in Australia, there's no formal recognised educational or vocational pathway for health workforce planners, policy practitioners, and program managers. So in order to fill the gap and meet market needs, we'll be offering postgraduate programs, executive and professional development short courses. These educational programs will help equip these health workforce planners to plan, attract, retain, and also develop the health and care workforce. In addition, we'll also conduct research activities through a wide range of channels, such as having a higher degree by research students, postdoctoral fellowships, as well as involving ourselves in all sorts of competitive grants programs. And last but not least, we'll be collaborating with our government and industry partners to support their policy and program design, health workforce planning, and other development opportunities. And next slide, please. In terms of the core functions of our centre, the first is developing and integrating the data analytics and capabilities. As Mark mentioned at the beginning, Australia has comprehensive data on health workforce, including data linkage assets, such as the Australian government's multi-agency data integration project, or MADIP for short, which is a secure data asset combining information on health, education, income and tax, immigration, employment, also population demographics over time. Also burden of disease and its background data are another set of important epidemiological data source. And because of our expertise, our center will be the first who explores these rich data sets application to health and care workforce modeling and planning. The second core function for our center is developing next generation health workforce modeling techniques. Ian will be showing us more on this later, so I won't go into any details. But for example, the techniques include the utilization and needs-based model, for which the burden of disease data are the critical part of the input, and sophisticated and robust supply and demand forecasting at the national and regional level, as well as by sectors or professionals. Another priority for us is conducting microeconomic studies of the effectiveness and responsiveness of to workforce strategies and policy incentives. As you all know, every year, government and industries spend lots of money on workforce, health workforce supply incentives and programs, such as different training programs for rural and remote areas, attraction and retention schemes. So are they good investments? We really need to do rigorous analysis of the responses of individual health professionals, also industry segments, to these incentives and policy interventions to better evaluate the policy and inform future policy decision and program delivery. Another core function of ours is the establishment of this integrated research and data platform. And at the moment, we do this with our internal engine room, the health data and analytics team, who are the experts nationally on the data and analytics in the field of health, especially health workforce. Can I please just go to the next slide? Now, just to give you a bit sense about our work, I'm going to briefly talk about a few current projects. The first one is a whole of jurisdiction workforce profiling and projections for the Australian Capital Territory, or the ACT region, where the Australian National University is based in. This is a 2-year collaboration with our strategic partners, including the ACT government, the Australian government, our local primary healthcare organisations, as well as private and non-government sectors. The goal of this project is to help ACT government improve its health workforce intelligence and forecasting capability to better inform their health workforce and service planning. There are a few key elements for this collaboration. First of all, we'll develop the workforce data infrastructure, based on which we'll apply advanced modeling and projection methods. We'll also work closely with our partners to upskill their data analytics capability in the area of health workforce. This project is also very comprehensive and covers all health programs and sectors. So apart from the hospital system, we'll also include primary health, mental health, as well as aged care sector. And this project is only for the ACT region, but as some of you know, in Australia, under the federated system, state and territories operate as like semi-autonomous entities, just like mini countries. And they all have authority to manage and govern their own respective health system. Therefore, this project is scalable, and all of the components and techniques can be applied to national level health workforce research, planning, surveillance, and intelligence. And next slide, please. Another project that is going on at the moment is really a showcase of our expertise in data-driven approach for health workforce planning. So we are working with the Australian government to develop a workforce planning tool which will guide the distribution of training and training locations for primary care physicians or general practitioners, we call here. This tool will be derived from analyzing and combining a wide range of population, epidemiological as well as administrative data sets. So these data sets are able to objectively measure the needs at the local population level. But prior to this project, these rich data sets haven't been used to do so. So our expertise comes in handy here. And similar to the first project, the tool we will develop here has broader utilization beyond this project itself. For example, the index and metrics derived from this project can be used to guide funding and training place allocation to all sorts of geographic regions. We can also apply this method or approach to other primary care settings and workers, not just GPs. So overall, this is a very good example of us using data and intelligence to guide, plan, and evaluate this needs-based health workforce policy and planning. And next one, please. We've got a lot more exciting projects that I would like to share with you, but conscious of the time, I'll just quickly talk about one more, which is the data scoping framework for the First Nations health workforce. As it is in many other countries, our First Nations people are many times sicker compared to other Australians. The latest Australian Burden of Disease study shows that Aboriginal and Torres Strait Islander people are about 2.3 times sicker than other Australians. And it has been shown that a strong First Nations workforce is a powerful driver of better Indigenous outcome. And it is also great news that there is a First Nation people, there are a lot of First Nations people working in health and care jobs compared to the First Nation people working in any other sectors. And in this context, the Australia's First Nations Health Workforce Plan was launched about 2 years ago with a target of doubling the First Nations health workforce size by 2031. So for this project, we're helping the Australian government to develop a data scoping framework to support this health workforce plan. This plan has several focus areas, including the supply of First Nations health workforce, the transition from education to workforce, also the culture safety for First Nations health workforce, as well as Indigenous data sovereignty and reducing the reporting burden. At the moment, we are working on identifying the available data sources, also their utilization in supporting this health workforce plan, also the strategies to fill the critical data gaps if there are. And so ultimately, our work will directly inform the implementation and evaluation of this health workforce plan. And now I'll hand over to Ian to talk about the really technical part in health workforce projection and planning. Thanks. Over to you, Ian.
Okay, thank you, Fan. Mark and Fan have given an overview of the kind of work we're doing. I'm going to drill down a little bit more to talk about how we're going about health workforce planning in Australia. And I guess the first thing to talk about is what we mean by health workforce planning in this context. And there's two components to health workforce planning and the way we conceptualize it. The first is the development of a projection of need. So in the first instance, the question is how many workforce actors do we need, over what time period and in what places. So that's the development of a supply and demand model and gap analysis. The second component is then a detailed plan about how you're going to go about filling those gaps in those places for those professions, for those needs. I'm going to talk about the first of those components because in our role, we're more interested in the development of an understanding of the gaps that exist, which we can then provide to administrators and policymakers and so on, who can then do the work of developing those detailed plans. I guess the other thing that's worth thinking about to begin with is why we would do workforce planning at a national level. There's an argument that the people who should be doing workforce planning are those who are responsible for individual health services, individual hospitals and so on. And it's certainly true that they need to do health workforce planning, but there are reasons why it's important to do workforce planning at the national level, and they centre around the way in which health workforce gets supplied. So through the migration programs and through tertiary education, those in Australia are responsibilities of the national government. And so it's important to have a national purview of those kinds of issues. If we're going to look at things like distributional issues across different regions of the country, across different subpopulations and so on, it's important to be able to get a national view of those kinds of issues. So again, it's important to be able to do national workforce planning. And there are, particularly in Australia now, major intersectoral issues. We're developing new programs across disability, aged care, and health, and they, to a large extent, as we know, share a workforce, and so integrated planning across those three sectors is an important aspect as well. So if we can have the next slide, thank you. So in terms of the workforce planning process, I guess it's important for us to emphasise that it's not just a technical exercise. It can seem as though, you know, supply and demand modelling and projection modelling is largely a numbers game, but health workforce planning has two very important components. The first is the technical process, but the second is dealing with the important stakeholders in the area and understanding some of the issues that are important to them. So if we look at the importance of stakeholders, we have to be able to develop methods for eliciting stakeholder input through things like scenario analysis, through Delphi techniques and so on. And we need to be able to satisfy ourselves that we've got input from all of the relevant actors across the health system. Secondly, we need to be able to arrive at consensus decisions because if we don't have consensus decisions, then we're not going to be able to move forward. We're not going to be able to get agreement across different jurisdictions, across different parts of the system to be able to develop integrated policies. It's important to understand differing power relationships. You know, there's a world of difference between doctors' groups, administrators of hospitals and so on, as compared to underprivileged groups in rural and regional areas. And if we're trying to develop plans to meet healthcare needs across the whole system, we need to understand how those different groups influence the way in which the health system works. So again, there's little point in developing a health workforce plan that pushes doctors, for example, into rural and regional areas if you've got no ability to be able to make that happen. Lastly, we need to be able to develop effective methods for communicating planning results. And that's obviously things like data visualization techniques, but it's also being able to contextualize the results of planning and be able to integrate them with some of these other concerns around power relationships, money, and other aspects of managing the health system. In terms of the technical process itself, there is a strong trade-off between the analytical sophistication of the model you're trying to develop and the data requirements. And I guess one of the lessons we have learned in developing the plans that we have is that model complexity is not a virtue in and of itself. And it's very easy to get carried away with the idea that the more sophisticated the model you build, the greater the precision of information that you're going to get out at the other end. Whereas in fact, you can find that you're misleading yourself about the level of precision that you're developing with your models. And in many ways, it's far better to have a simple model that makes best use of the data you have available to you, rather than try and develop a highly sophisticated model that takes account of large numbers of variables if your data don't support it, or indeed if the kinds of planning questions you're trying to answer don't need that level of complexity. So that final point there about clarity in the planning questions to be addressed is key. So before you engage in the detailed modelling process, it's important to understand the region you're trying to develop the plan for, the populations that you're developing the plan for, the professions to be included, the sectors that you're involving, and so on. And establishing those kinds of questions before you start engaging in the planning process is an important aspect. Next slide, thank you. So if we turn to the question of supply, this is a very simple conceptual model around the kinds of data that are needed to be able to develop supply estimates. So what we're trying to do here is to establish at a point in time what's the range of health professions that we have available to us to provide health services into the region we're interested in, for the population we're interested in. And then we want to be able to project that forward in time. So the kinds of questions we want to be able to answer are, given the kind of workforce we have at the moment, if we look forward 5, 10, 15 years into the future, is that same workforce going to be adequate for the kinds of health needs that we've identified? If not, where are the gaps? Which professions are there gaps in? Which areas are going to be underserviced? In order to be able to do that, we need to be able to measure the inflows and the outflows from the workforce over a period of time. So the kinds of things we need to know are who are the entrants to the system through our education system, through our migration system. To what extent are people increasing or decreasing the hours that they work? What is the rate of retirement of people from the system? Are there increasing rates of illness and so on? So if we think about the COVID-19 pandemic, then that's an important case study, if you like, in the impact of illness and increased stress on the workforce, and the impact that that has both in the short term over the period of the pandemic, and then in the long term in terms of the attractiveness of different professions or different areas of work for new entrants, whether there might be increased rates of retirement or reduction in work hours for people who already work in those sectors, and so on. So understanding the impact of things like that pandemic or other system shocks are important in understanding supply. So what we're aiming to be able to do is to take that point in time estimate that we're getting of our current workforce, apply those rates of inflow and outflow, and get our estimate of future workforce. So if we have the next slide, thank you. So conceptually, supply measurement is reasonably straightforward in the sense that we're just taking our current workforce and working it forward. Demand measurement in this sector is more complex conceptually, principally because demand for the health workforce is a derived demand. It derives from the demand for health services. So, people don't need a doctor as such, they need the services that the doctor delivers to them. And the question is, what's the level of services that people require now and into the future? So what we're trying to do is to establish the demand for services through the healthcare needs that we identify in the population. We translate those needs into a need for services, and we translate that need for services into a need for workforce. So it's a reasonably complex causal chain that we're trying to estimate. So if we look at demand for services, there's broadly two ways we can think about it. The first is looking at population healthcare needs, which we see as the ideal approach. So this asks the question, what are the chronic and acute diseases that are going to occur in particular populations, in particular regions? What is the prevalence and incidence at a particular point in time? And then how are those likely to change over, say, the next 5 or 10 years? If we can understand disease prevalence, then we can try and estimate from that how will that set of needs translate into a set of needs for services, and then we can translate that need for services into a health workforce need. The problem with that is that while it's an ideal approach conceptually, it's very difficult to measure directly. It requires a significant amount of data about your population, and most countries, including Australia, don't have the detailed data that you need for all of the diseases and conditions that you might be interested in to be able to use that as a basis for workforce planning. So most workforce planning solves that problem by making a simplifying assumption. And we basically say that the level of healthcare needs that exist in the community are currently being met. And the problem then becomes one of saying, well, if they're being met now, what do we need to put in place for our workforce to ensure that they continue to be met into the future? So in other words, we just take the current utilization of healthcare system resources, and we project that into the future, and we base changes in healthcare need essentially on changes to the population. So increase in total population, increase in those components of the population which are known to need more health services, in particular the elderly or subpopulations which are particularly high users of health services. Next slide, please. So this is just a diagram to illustrate what I've just been talking about. So there's two ways of looking at demand, but both of them start essentially with the population at the moment. And we use that as the basis for saying this is the set of people who require services in the country. We then look at population projections by age group and gender and geography, and we use that as the basis for looking at projections into the future to be able to estimate our need. A population needs-based approach takes those inputs, but it adds to it disease prevalence. So to take an example, we might look at prevalence of diabetes across the population, and we want to be able to segment that by age group, by gender, by geography, and so on. Then we want to be able to do two things. The first is to translate that into a set of needs for services. And we do that essentially by working with clinical experts who will be able to help us work through the level of services, the amount of services, the type of services that are going to be needed by a group of people with type 2 diabetes now and into the future, and we can then translate that into a need for health workforce. Then we want to take a second step, which is to say, given that's the level of prevalence of diabetes in the community now, how do we project forward that same that level of prevalence into the future? So what do we understand about our population to be able to estimate levels of diabetes prevalence in 5, 10, 15 years time, and then again translate that projection of need into a projection for services. So it's pretty clear that that is a pretty complex kind of process. So on the right-hand side there, we do a much simpler thing, which is to say, what's the level of use of services right now? And we can estimate that from things like the, a national health insurance scheme, if you have one, rates of hospitalisation for different kinds of conditions and so on. Then we'd be able to say, given that that's the level of services that are used right now, we know the level of workforce that provides those services, so we can translate that fairly readily into an estimate for workforce. Then we simply project forward the population and make an estimate. So it's pretty clear that a utilisation-based or a demand-based approach is far simpler than a needs-based approach, but the needs-based approach is much more conceptually defensible, and it's much closer to what people would understand by a workforce plan that deals with genuine population need. The other kinds of aspects that are important to think about in this area are, traditionally we've done workforce planning profession by profession, and in particular a lot of workforce planning is focused on doctors because they're the most expensive, the most powerful and the longest to train. A profession by profession approach is good if your objectives are just to work out things like how many doctors do we want to train in our training system, but it's not terribly useful if what you're wanting to do is to look at things like the optimal mix of professionals to be able to deliver a range of services. So you want to be able to develop scenarios to get a better understanding of changing workforce mix. If we're looking at things like changing scopes of practice and so on across different professions, then that becomes important. It's also very important to not treat health as a closed system, as we discussed earlier. So a lot of the workforce, particularly nurses and a lot of allied health professions, provide services not only in the health system, but also across the aged care and the disability sectors. And we need to be able to take that into account. And certainly in Australia, that hasn't been the case to date. Each of those sectors does its own workforce planning and takes little or no consideration of the needs of those other sectors. So to be able to properly workforce plan and workforce model, we need to be able to take into account the needs across those different sectors. The other thing is workforce planning has traditionally focused on professions, so it's largely ignored care workers, assistants in care and so on, and again, they are critical workforces, particularly in the aged care sector, and we need to be able to take that into account in our modelling as well. So if I have the last slide, thank you. But given all of that, what are the kinds of things we're trying to do? We're trying to develop modelling approaches that better account for population health need in aggregate. So that's trying to build that kind of population health need model that I talked about. We're trying to address distributional issues in regions and subpopulations, because again, that's really only something that's can easily be done at a national level. We're trying to measure the full range of health occupations, including assistants and carers. And we're trying to measure some of those boundary issues between health sectors and between health and those other sectors. And as Fan mentioned, we're looking at using some innovative data products, and we're looking at developing some new analytical techniques with our colleagues from the Health Data Analytics team. So I will stop there, and I think it's time for questions.
Well, thank you so much, Ian and Mark and Fan and Ankita, for really terrific presentations. I think highlighting the complexity of the issues and the need for a coordinated and comprehensive response. So it's time for questions. You can, as I mentioned earlier, you can post your questions in the chat or put up your hand. And I'm just going to kick it off with a question to each of our speakers. So Ankita, if I can start with you, having just come back from the global convening, from the Women Deliver convening, are there some best practices or innovations that you heard during your time there from other countries or regions that you think are particularly promising approaches?
Great, thank you, Jane. That's a really good question, and I wish I had a lot of time to go through all of the different best practices and innovations that emerged. I think I'm going to highlight maybe two that came up, one that relates to some innovations in Asia, and then one that relates to a really interesting best practice that we heard about in Latin America. But in Asia, one of our roundtables really focused on the role of digital innovations in addressing rising care demands. And it really looked at the role specifically of mobile platforms in facilitating care delivery. Our white paper provides some more information and details around the kinds of mobile platforms that exist to facilitate care provision. But three that come to mind are Kiddo Care, which is in Malaysia, Love Care, which is in Indonesia, and Homage, which is in Singapore. And what's really interesting about these organizations is that they each operate a mobile platform that families and households can download and can actually use in order to browse, book, and connect with local care providers. So depending on the platform, families can book childcare services or book a provider to support them with childcare or with elder care or disability care. And so it's a really interesting model that has been proven effective in facilitating care delivery within the context of those three countries. But like I said, our white paper shares other examples of mobile platforms that are being used in Bangladesh and in India and among other places in Asia. And so that was something that also came up in the roundtable discussion. And really the focus was, how can we adapt some of these platforms? How can we scale them both across the region, but also how can we expand them so that they're looking at the entire range of care needs? So providing both childcare and also elder care and long-term care support. We also discussed community-led models. I think that was a really interesting one. We talked specifically about the model of SEVA. I don't know if everyone here is familiar, but SEVA is a union of informal workers in India. And in fact, it might be the biggest union of its kind in the world. And SEVA operates a childcare cooperative, which is run by women in the informal economy and currently operates a number of different childcare centers for the children of informal workers who don't have access to private or public childcare facilities. And so it provides basic healthcare, education, and nutrition to these children who are largely from structurally disadvantaged families. And it also is unique because it employs individuals from the community to run these different facilities, and also provides trainings to help them develop their livelihood skills. So it's another model that we discussed, and those are just two things that come to mind for Asia. I also wanted to quickly talk about a really interesting model that came up in Bogota. We had a speaker, Diana Fernandez Franco, who's the Secretary of Women's Affairs in Bogota, and she spoke about the care blocks that the city of Bogota has implemented, which are these 11 essentially blocks around the entire city. And they're areas where care providers and families can essentially go and seek childcare, elder care, and disability care services. And they can access it. I think it's around a 15 to 20 minute walk for almost everyone in the city to at least one of these care blocks. and they can access basic healthcare, nutrition, and other types of services. And so what was really interesting about this model is that Diana mentioned that it's been proven effective in increasing not only access to care services and education, nutritional outcomes, but also they found that it's reduced crime in the city, and specifically is linked to a reduction in the rates of gender-based violence in the city of Bogota. And it's a model now that the national government is also looking at scaling across the country. So since Women Deliver, we've been thinking a lot about how can we scale or adapt some of these regional practices. And one idea is to scale something like this to Asia. And I think that there is such a model in Hong Kong, but also how can we have more of these models across the Asia Pacific region? That's something that we'll be exploring through this global roadmap for action going forward.
Thanks so much, Ankita. I think that what you've underscored with what you've shared is the issue of equity in how we think about access to care and choice in care. Mark, I want to ask you both about what you were sharing about the challenges in healthcare provision in a rural context, which is also a real issue in many countries in Asia and the Pacific, and how health workforce planning can benefit in thinking about this. But also just touching on what Ankita was sharing, how are you factoring in thinking about the gig economy in relation to issues of equity in health workforce planning? I know in Australia that many families are having to turn to gig workers to be able to provide responsive care when they can't access other healthcare services. But in that Uberized model, they're having to pay a premium, sometimes $150 an hour, just to access rapid care for family members with disabilities, etc. So whether it's access to care in rural areas or whether it's access to rapid care for a variety of different reasons, how are you thinking about issues of equity in terms of health workforce planning?
Thanks, Jane. That's a very broad question, but I'll start with the rural aspect first. Look, I think the critical issue that certainly we're focused on, the problems of access to quality care in rural or remote areas is a global problem. It just has slightly different flavors in different countries, but it's the same problem. If you live in an underserviced area, you wait longer, you sometimes pay more or don't get access to care. So our focus, which is very much on the numbers and the kind of data and research underpinnings of that, is to construct models that can more accurately reflect the disparities between access to services by type in geographical areas. So a lot of geospatial work combined with the very technical supply and demand modelling techniques that Ian went through. So we think the most important thing to do is the nature of the problem. And secondly, on the basis of that, when governments, and certainly our governments in Australia, spend an inordinate amount of money and time and effort in trying to come up with new solutions to solve long-term problems. And the thing that they're missing is, first up, a reliable method for predicting the effect of their policy changes, so they can blow a lot of money, spend a lot of money on things that look good but don't work. Programs over time so that scarce resources can go into priority areas. In relation to the gig economy, that's clearly an example of innovation, very rapid innovation. And I guess there are a couple of elements in our broad model that we would seek to use to respond to that. Firstly, and Ian talked about, utilisation models, and the basic assumption there, of course, is that you just model forward what's happened for the last 20 years, adjust it for population, and that's how many workers you need. Well, our models need to become a lot more sophisticated than that. We need to be able to build in technical aspects of our models and projection methods so that we can simulate the change of certain interventions, the increases of need for different types of workers, such as technical workers, and the potential decrease in demand and supply of more traditional regulated workers. So they're all things that we need to, and when we certainly will be, to build good predictive models to guide decision-making by governments, guide decision-making by the people who run healthcare, health and care organisations, but most importantly, a loop back to the training and education sector so that they are training the sorts of people that are needed for a changing health and care delivery system.
Well, I'm so glad that you have co-created this new centre, because it really feels so timely and so much needed, given the issues that we're discussing. Fan, I want to come to you now with what you shared about the First Nations workforce plan, to ask how you are working with First Nations peoples to be able to support the data access, and particularly given the sensitivity of issues, including Indigenous data sovereignty, both from a cultural perspective, of course, as well as to protect from issues of discrimination. And just wondering how you are actually working with First Nations peoples in relation to different elements of that plan.
Great question, Jane. I thought so on this, I might give a kind of high level summary about our approach. And I might ask my colleague also, from the health data analytics team, who's actually leading this project, could give us more broad or more detailed response. So for this, our general approach in all those projects, especially on data projects related to First Nations people here, we adopt like a co-design approach, because First Nation people, they will be using whatever framework or plans or strategy that we take the initiative for them. However, they will be the end user of them, and we really appreciate their contribution, their culture, like every aspect they can to with us in this project. Especially when we talk about data, they're not just data, they're not just numbers, they are all real people behind the numbers that we put together, as well as modeling. And the ultimate goal for any modeling and health workforce planning, the outputs we do is to, we want these to be useful and helpful for them, right? So that's a general approach. And now I'm gonna ask my colleague, Tomiko Suguru, and who's leading this project, to give us more detailed explanation on that. Tomiko.
Oh, Tomiko, I don't think we can hear you. So perhaps we'll come back to you. We're just having a problem hearing you at the moment. So perhaps I'll come back to you after asking Ian a question. Thank you so much, Fan, for what you shared, and we'll look forward to hearing from Tomiko once she's got her sound back.
Sure.
But while we're waiting, Ian, with what you shared as a fantastic model for thinking about data and health workforce planning, how do you think this approach can translate to other countries? How can we think about replicating this approach that you're engaged in Australia, particularly given that many other countries, particularly in the Pacific, but also a number of countries in Asia, don't have access to a high level of accessible data. There's real data paucity to really work from in terms of it being a tool for workforce planning.
Yeah, I think, as I said, one of the traps with workforce planning and workforce modelling is to take the most sophisticated model you can find in the literature and try and apply that in your context. And in a lot of ways, you can use the kind of information that's already collected because of requirements for national accounting purposes and national census and so on, that countries provide to WHO and other kind of international bodies, and you can get a long way with those data sets. And so certainly you can get quite a good picture of your health workforce using things like a national census, and you can get a pretty good idea from your national accounting framework how much your health sector is costing, and information about what it's delivering on the ground is going to come from the health system itself. So you don't need to have really sophisticated data collections in place. You know, whilst it would be great to have a needs-based, population needs-based model, Australia doesn't have one, England doesn't have one, America doesn't have one, Canada doesn't have one. They've all been getting by with utilization-based models forever. So I think the thing to do is to get a basic understanding of what your health workforce looks like right now, and some basic measures of what it's delivering in terms of services, and you can get a long way with your health workforce planning just with that. So a very simple conceptual model is absolutely fine, and I would caution against the idea of rejecting the notion of health workforce modelling just because you can't get all of the sophisticated epidemiological data that you might need for it.
Very encouraging, I think, to those on the call. Thank you so much. Tomoko, can we just check your sound and see whether we can hear you?
Okay, sure. Can you hear me now?
We certainly can. Thank you.
Okay, great. Thank you. So answering the earlier question about Indigenous data sovereignty, data sharing, how do we really demonstrate our ability to listen to the voices of the Indigenous Australians? The approach we are taking is co-designing of the product we make. Because we are based in Australian National University, we also actually have a large number of Indigenous health researchers, medical researchers, who contributed to the initial work on coming up with the National Aboriginal Torres Islander Health Workforce Strategy. We are helping the strategy to be implemented. So we have access to voices of the people who made the strategy, which is a really one way to make sure that non-Indigenous Australians such as myself are able to kind of create a product that is useful and resonates with roughly 1 million Aboriginal Torres Islander people today. Another aspect is in our work, we need to better get a better understanding about what's the in-scope professions or occupations. It's about doubling the workforce size from today in 10 years. And what Aboriginal Torres Islander people would like to see grow may be very different to mainstream Australians' conceptualization of health workforce. So we are very careful to listen to what these professions, occupation may be, and do we have data today? If we don't have data, then our job is to ensuring that we are clear about the ambitions and dreams and hopes of Indigenous people in terms of what professions they would like to see grow. Data sharing is a very important part of Australia's key Indigenous health policy called Closing the Gap. It started in 2012 and it's now got 17 targets. In fact, one of the 4 things that's working out is employment. So I think there's a lot of aligning of the stars that supports our work, and we are also really learning from the engagement that we have with the First Nations people. So thank you for the question.
Thank you so much. Turning back to you, Ankita, how do you think that international organisations can adapt the momentum from these regional and global convenings that you've been engaged in to translating that to national level action? We've started to do that in some countries. There's a lot, I think, that we're learning here today in terms of some good practices and tools to be able to do that, and ensuring that the approach is really integrated and taking into account some of the most marginalised populations. But it would be great to hear your thoughts.
Thanks, Jane. As you already mentioned, we are already doing a little bit of that at the Asia Foundation. Since the Bali Care Economy Dialogue, we've been working with some of our country offices to really translate some of the outcomes that emerged in that convening into their programming within their context. And so we're working closely with our country offices in Malaysia and the Pacific Islands to do this work. In the Pacific Islands, I just wanted to call that one out because one of the big findings from the white paper was that there's very little evidence and data as it relates to the care economy in Asia and the Pacific, but specifically most of the data that exists focuses on Asia. So there's almost no evidence or data that focuses on the care economy in the Pacific Islands. And because of this, our Pacific Islands office indicated an interest in delving deeper into this topic. And so we are currently working with the Pacific Islands to conduct a study that focuses on just what is the state of the care economy in the Pacific Islands. So conducting that analysis to better understand what are existing regulations, as well as resources, and who are the existing actors that are working on the care economy in the Pacific Islands, and what are some of the big gaps. So, I think that kind of an analysis will be really helpful in both addressing existing gaps, but also in helping inform future programming. And the idea is to organize a convening in September that will delve into this topic a little more in the Pacific Islands. Some of our other country offices, including Mongolia, which is now working with the National Gender Equality Commission and Women for Change, and also our country office in India, Thailand, Nepal, or other country offices that have indicated interest since Bali in actually conducting more care-specific programming. And so we're working with them to see what's possible. I would also end with just two more things. I think that it's going to be really important for us to think about how can we secure the funding needed to translate some of these insights into programming. This was a big takeaway that came up in pretty much all of the convenings that we've had and in all of the conversations. But unless we're able to tap into the different diverse sources of funding, it will be difficult for us to carry this work forward. And so it'll be very important for us to talk to the public sector, but also different, private sector actors to really see what's possible and how can we channel some of those fundings to replicate or to introduce more innovative care practices on the ground. And then the second thing that I would mention, again, goes back to my earlier point, but we also need to invest in stronger data. In order for us to secure the funding for the care economy, we also need to make a case for why the care economy is important and how does it link to overall economic outcomes or human rights outcomes. And right now we don't have the data that makes this case. And so it'll be very important for us to focus on collecting that data, both focusing on quantitative, qualitative, but also participatory data. So how can we work with care workers and communities to capture this information that we can then use to secure funds to actually run programs on the ground?
Thanks, Ankita. Very exciting time, I think. Mark, I just want to build off what Ankita shared in terms of our work in the Pacific, for instance, and ask you whether, first of all, what you think some of the lessons are from the pandemic that will inform health workforce planning. And also, is the centre looking to adopt not just a national approach, but a regional or global approach in terms of its thinking? You mentioned before the issue of migration, often a complicated issue. How are you also thinking about not just how to strengthen health workforce systems in Australia, but more regionally as well? Because if they're stronger regionally, then another pandemic, there's actually a better infrastructure to be able to cope with that. So it would just be good to hear your thinking in that regard.
Yes, look, thanks for that. And thank you, Ankita, for that, for raising that. Yeah, look, the short answer is yes. There is while obviously our initial focus is Australia, that we're in the business of generating knowledge, research, and data capability for regional and potentially global kind of applications. So the kind of notion of partnering into these sorts of bodies of work is very much part of what we're focused on, and indeed the ANU has already got a number of kind of arrangements in place throughout the Pacific in particular. So I think just going back to Ankita's point, getting the data right about migration flows is absolutely critical. We are currently doing a body of work that is looking at COVID-19 impacts on migration flows. It's relatively straightforward for us to look at the main kind of established health professions. It's a little bit more complicated to look at the broader care workforce. And I think the other reason why we need these kind of integrated regional data collection approaches is obviously to support the work that organisations such as yourself are doing, or to make the case for it. But also there are a lot of concerning migration practices right throughout the world. And I think we just need to kind of call that out. There are wealthy countries like Australia, like New Zealand in the Pacific region, whose very economy depends upon a regularised flow of skilled and semi-skilled migrant workers from the Pacific, and indeed other parts of the world, but we're talking about the Pacific in this context. And so I think it's really important to get a deeper understanding of what a two-way flow would be. I mean, I think a policy response that recognises there is going to be a flow into the wealthier countries is to ensure that it's there's a structured way of kind of paying that back. That can be through skills uptake, better regulatory approaches, more internationally recognised micro-credential and micro-skills while they're practising as they need to for economic reasons in some of the more the wealthier countries in the region. So I think getting a handle on the data, getting a handle on the flows, understanding the economic benefits to source countries in the Pacific of this kind of this flow of migrants, and most of them, a lot of them are going into the care workforce. Certainly in Australia they are. Doing a proper kind of economic analysis of that, and then sitting alongside that would be to explore in some detail, in a qualitative sense, the equity impacts of that, and then I think once you've got two sides, the economic and the social sides, kind of measured, then I think more regionally focused policy responses can be much better informed, and we think that's a really exciting area of work. But at the moment, we're just focusing on skilled migration flows in and out of Australia in the pre and post-COVID era, but we'd certainly be keen to look at some of the broader aspects of that in the unregulated care workforces. Thank you.
So would we. So really glad to hear what you've just shared, Mark. I was actually going to ask a question about the role of AI as well, but I'm conscious of time. So with the remaining few minutes that we have, I just want to ask each of you, starting with you, Fan, one takeaway from this conversation, from this event, that you'd like to emphasise or share with participants on the call. And if you could just maybe just keep it to 1 minute each, I'm just conscious of time as well.
Great. Thanks, Jane, for the opportunity. So I think one of that many takeaway messages for me, for sure. But if you ask me to choose one, I would think, so apart from those mainstream, so-called health workforce, and so for the care assistant workforce, for aged care, disability care, and even early child care and veterans care, it's really important and critical for us to look at this care economy as a whole, because they share many contributing factors for the supply side and for the demand side. And moving into the deep future, the needs-based workforce planning for this whole care economy is so important, and not just in hospital system. I'll stop here. I hope only for 30 seconds. And
absolutely, you've made a very good case for why we're having this event today, the intersections of care economy and health workforce planning. Ian, your one takeaway for everyone on this call.
Yeah, I think similar to Fan, the workforce planning can easily become fixated on the high-end health professions, particularly doctors, and I think we have been guilty of ignoring a great deal of the way in which care is delivered in the community, and it would be, I think, exciting to be able to try and take into account some of those other aspects. There's an enormous need for it, but there's also an enormous data gap. So there's some real challenges there about how we would establish exactly how to measure some of those things, even in a country like Australia, let alone some other countries in the region. So I think that is an exciting area for us to have a look at in the future.
And I think if anyone can crack that, Ian, it's going to be you. So glad you're on that team. Mark, your one takeaway.
Yeah, one takeaway, and I think I'm just echoing what Ian sort of said in his presentation and questions before, which is really start with something that you've already got in place in terms of kind of, data collections and mechanisms. Start with what you've got and make the most of it, because what we find is there's stacks and stacks and stacks of data sources lying around not being used before we get to the other effort, which is coming up with new data sources and new models. Really mine what you've got already and share.
Well, I think that's just such an essential lesson for everyone here, to not be afraid that you don't have enough data to start that process, no matter what community or country. And Ankita, your one takeaway for everyone on this call.
Thanks, Jane. I definitely echo what Ian, Mark, and Van have all mentioned. The one other takeaway that I would add is that it'll be really important for us to ensure that we're engaging with care workers and communities in the design of research and programming and in policy. It's really important that they are front and center in this conversation. And so it's been really great to hear about this work being done with Indigenous populations. And now we need to ensure that care workers are part of these conversations in order to develop programs that meet their needs and are truly community-centered.
Absolutely critical point. And I think care workers, those needing care, and also families of those needing care, all of those platforms, those alliances, those networks are absolutely crucial. In fact, I was recently speaking with one of the senior directors of the healthcare system in the UK, and she was saying that she saw that as one of the gaps in their country, that there needed to be a strengthening there. So that's a challenge and an opportunity. So everyone on the call, thank you so much for joining. That's a wrap. I want to thank our incredible speakers for such a stimulating, thought-provoking session, a real, I think, engagement on what a comprehensive approach to care economy planning, health workforce planning looks like. It's definitely a priority focus for many of us joining this call, and it's clear that we've got a lot of work to do ahead to mobilise the resources, the political will, the policy influence, as well as those programmatic imperatives that are needed for resilient care ecosystems and robust health workforce planning. So thank you to everyone who has joined the call. We will share the recording with you, as well as those who weren't able to attend. So please share on your social media networks, and we're also posting the contact details for Fan, for Mark and Ian in the chat, and of course all of you know how to contact Ankita. So thank you again for joining, and thank you again to our amazing speakers for such an incredible session today. And so thank you to all. Good morning, good evening, good night, depending on where you are in the world. Thanks again. Bye-bye.